Thank you very much. I'd like to thank the organisers for the invitation and also for this beautifully opaque title. In fact, after the statutory staring at it for about 3 months, I decided there was only one word that I understood, and that was endpoints. So I'm going to run with endpoints. Now, we've actually heard quite a lot about endpoints already today, which makes my job an awful lot easier. And we've spoken a lot about amputations already. And we all know that this is a far too frequent endpoint of diabetic foot disease. And we've heard so many data already today. We already know that it's the leading cause of non-traumatic amputation, and that patients with diabetes are up to 15 times more likely than patients without diabetes to undergo a major amputation. That's an endpoint. We know all of this. We've also seen the variation in amputation rates across the US and also across the UK. That's an endpoint, not a great one, and we need to think about why that variation exists. We've also already heard about mortality. We've already seen a slide very similar to this, showing that patients with diabetic foot ulcers have very similar mortalities to some of the major cancers. And we've also had a whole session on the cost to society, the endpoint of cost. And this is actually the annual incidence of diabetic foot ulcers, showing again the comparison with major cancers. And in terms of actual financial cost, we had a whole session on the cost. I'm sure that these, the 17 billion per annum data that I picked out of the literature are probably inaccurate. Certainly the data from the UK are probably a little bit more accurate, and that's £650 million a year, or £1 in every £150 of the NHS budget. These are all endpoints and not great ones for our patients. But I went back to the dictionary, as so many other speakers have, because none of us understood our titles. And an endpoint is described in the Oxford Dictionary as a point marking the completion of a process or a stage of a process. And I thought, well, great, I've got something to talk about for the next 8 minutes or so. Because we know about the absolute endpoints, but what about the bits in the middle? And I borrowed this slide from Lee Rogers some years ago, and I've shown it hundreds of times. And this is the stairway to amputation, which beautifully describes the different stages people go through. And of course, it's not inevitable that patients with diabetes develop the complications of neuropathy, arterial disease or deformity. It's not inevitable that they go on to ulceration or even amputation. We can allow them to step off this stairway, or we hope that they will. And I'm going to look at this stage in particular and the possibility that we actually might heal the ulcer and therefore reduce the risk of the patient having an amputation. Because we know that if we do heal the ulcer, then it is unlikely that they will go on to lose a leg. So I want to think a little bit more about the endpoint of ulcer healing rather than the dramatic endpoints, which we've heard so much about, of cost and amputations. And my job is considerably helped by the fact that the International Working Group of the Diabetic Foot regularly produces systematic reviews and guidelines. And in fact, we heard an awful lot about the work of the International Working Group of the Diabetic Foot and their step-by-step program this morning. But we've heard less about a lot of their other work, which is regularly producing guidelines. And we also heard in an earlier session that perhaps organisations such as this should look at wound healing processes and products and produce guidance and support in people choosing these agents. And this is exactly what the International Working Group is doing. In fact, this is the systematic review which was followed by guidelines that was published in 2012 and looked at all the literature published between 2006 and 2010, and we are in the process now of updating those guidelines and systematic reviews to be published next year. I'll jump to the conclusions of the paper, in case you haven't read it, which of course I'm sure you all have. And that is that there's meagre evidence to support the use of any particular interventions in wound healing. But that's usually because the methodological quality of the reported studies is rather poor. And then, in fact, even those which showed some positive results should be interpreted with caution. We actually identified over 1,300 articles, of which only 43 in that 4-year period were included in the review because we were particularly looking at controlled series. And the reason why, these were the kind of agents we looked at: debridements, dressings, oxygen therapies, negative pressure or vacuum therapies, growth factors, cell therapies, skin substitutes, physical therapies such as electric shocks and ultrasound. And when we're looking at the endpoints, there were almost as many endpoints as there were papers published in that series. There were a lot of them were about healing, but they were healing at 6 weeks, 8 weeks, 12 weeks, 15 weeks, 16 weeks, 20 weeks, 24 weeks, 26 weeks, 12 months, 92 weeks. Healing defined as suitable for self-healing or for skin grafting, time to healing, time to wound being suitable for surgical closure, and time to healing. In addition, there was healing with limb intact, which is one I particularly liked. Reduction in ulcer area at 4 weeks, at 6 weeks, at 30, 45 and 60 days. Completing healing or more than 50% improved, a combined endpoint: reduction in area, 75% reduction in area, 60% reduction in area, rated change of ulcer area, time to complete granulation, time to 90% granulation, partial or complete granulation, or the instance of amputation. How on earth can we compare therapies when we've just got such a wide range of endpoints to look at? So which is the correct endpoint to choose? Well, that's a rather difficult one. Here's a patient with a very large ulcer, neuropathic ulcer, quite deep. Now, I would argue that it actually doesn't matter to the patient whether that ulcer is 90% granulated or 50% smaller or slightly less deep. What matters to the patient is that that ulcer still exists. They still have to attend for dressings. They still have to attend for regular debridements. They're still trailing all over the county for treatments. They still have to wait in at home for the district nurse to arrive to do their dressings. Until the day that ulcer heals, the patient is not going to be happy. And so we should really avoid surrogate markers which make us feel better, that it looks a bit better. That's not what matters to the patient. And these are some data from a trial of 3 dressing agents that we ran from Nottingham, which was published in HTA Monographs in 2009. The 3 different dressing agents were simple non-adherent dressing, Aquacel, or an inidine dressing. In fact, there were no differences in healing between the 3 dressings, so the data were pooled. And these are the quality of life data using the Cardiff Wound Impact Schedule, which is a validated wound quality of life scale and is divided into 3 different sections: physical well-being, social well-being, and overall well-being. And you can see here the data from 12 weeks and 24 weeks, and the difference in the blue between the patients who hadn't healed at those time points and those that had. And you could see, vast improvements in the patient's well-being in all scales: physical, social, and overall well-being, whether the patient's healed at 12 or at 24 weeks. In fact, it looks as if overall the patient's well-being was worse if they hadn't healed by 24 weeks. Presumably they were getting even more upset about the fact that they still had an open ulcer at 24 weeks. And it didn't really matter whether the patient's ulcers were big or small, their well-being didn't improve until the day they healed. Now, we'd thought about this some time before and published this paper in diabetes care, looking at the difference between ulcer-related and person-related measures, because to us it was important that the patient felt better. And it wasn't just a question of whether their ulcer looked better or healed. And one of the things that we noticed was that when you looked at individual ulcer data rather than person data, the data looked rather different. So here we had a series of 449 ulcers. 65.5% eventually healed, 12.5% which didn't, and 8% of those ulcers were resolved by amputation. But when we actually looked at the person rather than the ulcer, we discovered that, in fact, only 45% of the patients were actually ulcer-free at 12 months. So they either had a recurrence of their ulcer or they had 2 ulcers and only one of them healed. That 24% of them had any active ulcer, and in fact any amputation, because they could have had a contralateral amputation, again were quite higher. And this shows the importance of looking at the person and not just at the hole in their foot. In fact, we had a whole range of outcome measures, of which my favourite is being alive without amputation and ulcer-free, and a range of others being alive, ulcer status without amputation, being ulcer-free, whole range of them. But not one of these actually, interestingly, mentioned what Chris has just discussed, and I didn't know what the content of his talk was going to be about, because I didn't understand his title either. But what we didn't include was any measure of ambulation. Earlier on last year, the physiotherapist that works with me in my current clinic in Derby looked at the functionality of 50 patients, 50 consecutive patients who had major amputations a year after their major amputation. And she used this scale, which was actually developed to look at ambulation with prosthesis, but it could be easily applied to the patient's pre-amputation and pre-prosthesis. And A is basically a patient who is non-ambulatory, so hasn't used their prosthesis and is completely non-ambulatory. And you can see that a huge number of our patients post-amputation were non-ambulatory. And so we're very concerned about our outcomes functionally after amputations, and we're now working a lot harder with our surgeons to make sure that the patients that we choose to go for major amputation are the correct patients. So going back to the systematic review, one of the things that was important to us when looking at these studies was not necessarily the outcomes or the endpoints, but actually what was being studied in the first place. Because what the patients that you put into your study is going to have a huge impact on what you measure at the end of it. And what was interesting, again, was the huge variety of different studies that were in this series, and that there was even combinations of venous leg ulcers and foot ulcers, entirely different pathologies. The majority of studies actually excluded patients with ischemia, although the ABPI cutoff was quite variable, somewhere between 0.4 and 0.9. Interestingly, baseline size of the ulcers was not given in every paper, and yet we know that area is such a profound predictor of wound healing. There was a variety of different wound types. Some were post-surgical, some were non-surgical wounds. There was actually quite a widespread use of the Wagner classification. That actually doesn't really help you when you're defining a wound. Is this wound the same as the one that was defined in the study? Because Wagner classification is rather depth-based more than anything else, and is a bit of a clumsy tool. And in fact, the majority of ulcers were non-infected. Just talking about classification systems, there are a wide number that are published. As I say, the Wagner was one of the most common, but is probably a little bit clumsy for this sort of area. The University of Texas, which is most well known in the States, but actually doesn't include neuropathy on the scale. The SAD-SAD system, which was one that we devised in Nottingham, which size area depth, sepsis, arteriopathy and denervation, and SINBAD, which has been derived from that, which is a much simpler tool. PED is derived for research as a research tool. The Levine O'Neill, Van Acker Peter Dus sign, which was actually designed for prediction of ulcers. The IDSA classification for infection, and the Lipsky scale for hospitalized patients. And at the moment, there is no one scale classification system which has been approved for any particular use. But again, this is something that the International Working Group is actually looking at. I also want to think about the timing of any endpoint that is measured. And again, I take you back to this slide, the huge difference, timescales, variation in timescales of these endpoints. And this is quite important. If you just look at this trial of a wound agent, you'll see that the active agent is in the black line and the patients in the white dots had placebo. And you can see that if you looked at the wounds between somewhere around 60 to 70 days, there was a difference between the two groups. But actually, by 112 days, there was no difference between the two groups. So if you'd done the assessment quite early, you might think actually there was a real difference between healing between these two groups, but if you followed them up a bit later, there wasn't. And so obviously timing is quite important. But if we pull out the timing too far, then obviously the patients may not survive, and this is neuropathic ulcers, patients presenting with a first neuropathic ulcer where their median survival was 8 years. These are our own data from Nottingham, and data that you saw earlier on that Andrew Bolton presented from Stefan Moorbart's work, showing the huge increase in mortality in patients presenting with foot ulcers. You'll see just under the darker column row labelled death, all patients, 15% died at year 1, 33% at year 3, 45% at year 5, and 70% at year 10. So even at year 1, 15% of the patients had died. So if we extend our studies out to 12 months, we can expect a significant mortality, and therefore any change in wound healing may be lost. So what are we actually doing with all these studies and endpoints? Why are we interested in this? And that's really because we need evidence. We need evidence that any intervention makes a significance to and improves a person's well-being, and not just makes the hole in their foot look a little bit better. And that's in order to apply that to our patients' care. And we've already discovered we're working in a cash-limited society. That's been discussed several times today. And that means if you spend money on one thing, something else is lost somewhere else. And so I just want to think about trial design and conduct in the last few minutes. When we're looking at a trial to make a difference, we need to think, to what is it making a difference? In who are we looking for it to make a difference? Compared with what? When are we going to assess that difference? And who is going to determine the difference? So what makes a difference? I would suggest that when you're looking at trials and looking at evidence of what makes a difference, that you're really looking for person-centered outcomes, and not just looking at the fact that an ulcer may be better granulated or not. You need to look very carefully at the population definition and think, these are the patients that I'm seeing in my clinic, because actually many trials exclude severely ischemic patients, and there's virtually no trials in patients with renal disease. All trials, when you're looking at these things, should be controlled. So you need to know what it's being compared with. And I think these days, comparing newer advanced wound therapies with saline moistened gauze probably isn't adequate. You ought to be comparing with the best that's available now, and with adequate offloading. When do you actually determine the outcome? Well, that depends on what you're looking for. If you're looking for survival, then you need to go out beyond 1 year. If you're looking at healing itself, then you probably need to go on a shorter time scale. And who determines the outcome? Well, we probably need blinded assessments of healing, and that's to reduce bias. And you'll be pleased to know the International Working Group of the Diabetic Foot, in conjunction with UMA, are also working on standards of reporting for clinical trials. So we hope in the future there's not such a variety of endpoints, and it will make it slightly easier for you to compare one outcome with another. So take-home messages, not that any of us are ready to go home just yet. It's the long-term outcome for patients with diabetic foot disease may be poor, but there are many stages between the beginning and the end to consider. That we should be considering patient-centered endpoints above single ulcer endpoints, and that the current evidence for interventions to enhance wound healing is poor, but the standard of the trials is rather poor, and there was certainly huge inconsistency in the reporting of the trials, but that work is being done to address that. Thank you very much.